I'm going to start out with just a couple of questions. We are doing some polls. We're going to integrate that, and we'll take questions. Every once in a while I'll stop and make sure that what I'm talking about is clear. But I do want to go ahead and see where our audience is from today. So you should see an instant poll on your page. We've got our 4 states, and then we did do some out-of-state marketing as well. So I wanted to gauge where our folks are calling in from today. All right, holding pretty steady there. All right, we've got the majority from Indiana, which I kind of suspected since we are from Indiana. 47%, 25% from Illinois, 11% Michigan, 6% Ohio, and 10% other. I'll go ahead and share those results so you can see that. And let's see. The other question that I did want to ask, let's do that, and then let's go to question number 2. And I would like to know what type of organization that you work for. This will help me to make this content as much tailored as much to the participants as possible. So we've got a lot of FQHCs, hospitals, or some RHCs. A lot of other. Okay, I'm going to end the polling now. We're pretty stable here. Okay, I'm going to share these results. So if you identified as other on this list of what type of organization that you work for, would you please put that in the Q&A just to give us a good feel for where our audience is from today. All right, thank you very much. Let's go ahead and get started. As I said, my name is Becky Sanders. I'm the Program Director for the Upper Midwest Telehealth Resource Center. We are part of the Indiana Rural Health Association, so we are all employees. Heidi and Luke are going to be monitoring questions behind the scenes for me today through that Q&A, and we will answer as many questions live as we can. We will record, or we actually are recording today's session. We will post it on our YouTube channel. We will post links to that on our website. We will post also the slides from today on our website, and we'll email those out to all registrants once we've got that done. So early next week, you should see an email from us with that information. Let's see, what other housekeeping? I think that's it. Luke or Heidi, if there's anything else that you're seeing, I'm not going to pay attention to the chat and the Q&A. It'll just throw me off. So let me go ahead and share my screen. I'm going to share screen 2 here. And I'll move my PowerPoint over here. There we go. So I already introduced myself. Today we're talking about starting a telemedicine program during the COVID pandemic. Luke and I have just been overwhelmed really with the tsunami of we call them technical assistance questions over the phone, via email, through the web pages, either through the National Consortium of Telehealth Resource Center webpage or from the Upper Midwest Telehealth Resource Center webpage. So we wanted to try and gather some common questions. We had a lot of people because of the social distancing requirements right now that are kind of thrown into, okay, if we're going to take care of our providers, then we have to do telemedicine because we can't see them in person. So we wanted to bring information to you as quickly as we could. I'm going to talk about today the National Consortium a little bit more, what it is and what it does, and then our role as the Upper Midwest Telehealth Resource Center. Really, I'm going to spend the majority of our time today on Telehealth and Technology 101 and try and answer as many questions as we can. At the end, we will go into a little bit of what's Medicare doing, what kind of waivers has Medicare done to include telehealth more universally during this particular pandemic. And also we'll get into high level state telemedicine rules. All 4 states that are in our region, Illinois, Indiana, Michigan, and Ohio, have done executive orders and have Medicaid waivers in place to allow for telehealth from the person's home. And that is a huge change. We're also seeing broad recognition, I guess is the word, from large insurance companies saying that yes, they will cover telemedicine and for a larger variety of disciplines than they ever had before. I just saw something from this morning from United Healthcare saying that they would pay for occupational therapy, physical therapy, one other thing that they normally didn't cover via telemedicine, but given the conditions we're living under right now, they are going to do that. And then we'll save time for Q&A if we need to run over our hour to try and get as much Q&A answered as possible. Luke has been working on updating our frequently asked questions on our website, so you'll probably see a lot of those questions answered on our website if we don't get to them today. All right, so here is the map of the National Consortium of Telehealth Resource Centers. You can see that there are different colors for different regions of the United States. You can see that our color is lilac, so Illinois, Indiana, Michigan, and Ohio are the states that we cover. We try and stay up to date on the Medicare policies, or Medicare's national, but the Medicaid policies for each of those 4 states. Also any private payer laws, other laws and regulations. We'll try to get into some of those today as much as we can. You also see there's 2 national resource centers. I'm going to mention those specifically later on today and give you some additional resources from those 2 organizations. The National Telehealth Technology Center is based out of Anchorage, Alaska, and we'll talk about that as them and some of their toolkits as we look at telehealth platforms today. And then the National Policy Center is the Center for Connected Health Policy. They're out of Sacramento, California, and we will look at some of their resources today. The 14 of us are all federally funded under Health and Human Services, Health Resources Service Administration, or HRSA, and then under the Federal Office of Rural Health Policy and the Office for Advancement of Telehealth. The Office for Advancement of Telehealth does provide our federal funding for the Telehealth Resource Center program nationally, as well as a lot of other telehealth programs. So the 14 of us have banded together over the last several years, and we do have a national website. There is a national webinar every month. Just last week we did the March webinar, and there was a lot of talk about COVID on that, COVID policies. We can get that link out to you guys. They were, those webinars generally have, I don't know, about 100, 150 people at them. We had a record number of attendance, unprecedented. We had over 9,000 registrations and over 5,000 people actually join. So hoping today is a little bit more manageable. It looks like we're somewhere around 120 last time I saw the count for who was on today. What do we do? So we call ourselves, or I call myself, a virtual librarian. A lot of what I do is answer questions on the computer, point people towards different resources, connect people with other programs. We do a lot of presentations and trainings. I have a feeling they're going to be pretty popular over the next couple of months. A lot of presentations virtually like we're doing today. We also help with project assessments, and I already mentioned that we keep up with policy and reimbursement for our 4 states. Heidi, that's joining us today, is in charge of our social media and marketing, and we now have a LinkedIn page and a Facebook page. You'll see posts on those on a weekly basis. So you can reach out to us through those mediums. And we also have a newsletter that you can join if you go to our main site and click Join Newsletter. Telehealth versus telemedicine. So this is the basics. This is where we start. I try not to use those terms interchangeably, but I know sometimes that I do. When I use the word telehealth, really what I'm talking about is the broad field of healthcare and data where it's mixed together. It could be things like using health data from a personal fitness device. It could be education. We're going to do some webinars for diabetes self-management later actually in April. Any of those things, remote patient monitoring, those are considered telehealth. When you talk about the billable clinical services, the E and M, the evaluation and management codes, those HCPCS and CPT codes that you bill for Medicare, Medicaid, and private payer services, those are telemedicine. When I think I've got a couple of slides, we'll talk about virtual check-ins today. Try and keep it really high level, and we'll do other webinars in April digging more into reimbursement. We're just going to keep this really high level and really basic today. So if you have a telecommunications background, you're probably familiar, or if you like walkie-talkies, you're probably familiar with these two terms. When we refer to telemedicine, and really pre-COVID, telemedicine was live and interactive telemedicine. So you have a two-way audio-visual connection between the patient and the provider. And it had to be HIPAA compliant. There are some waivers. We will talk about that later. Right now for COVID-19. Asynchronous. So asynchronous is a great use of telemedicine when you're talking about dermatology or pictures of wounds, pictures of rashes. It's not billed via telemedicine, but the most popular type of asynchronous telemedicine is radiology. You think about it, you're with a radiology tech or labs really too. They take your blood, or they take an x-ray and it gets sent off somewhere else to be read and analyzed, and then the information comes back later. What I really want to stress today is telehealth, telemedicine, it's not a different service. We're using technology that we have today in today's environment to remove the distance between a patient and their provider, to deliver the same service. For the clinicians on the call today, you're still a nurse, you're still a doctor, you're still a physician assistant, you're still a psychiatrist. You're going to use those same clinical services using your license to the fullest of your capability, but you're not going to be able to touch your patient. We want you to be able to see your patient. We'll talk about vitals and consent forms and that kind of stuff. But telehealth is a delivery modality or delivery mechanism for connecting with your patient. All right, so let's go back to HIPAA. Medicare and all the Medicaid states that we're going to really focus on today, Indiana, Illinois, Michigan, and Ohio, all have relaxed HIPAA rules. So you can see our resources there. We have a whole new resource page on our website devoted to COVID-19 resources. In Illinois, in the Illinois Executive Order, it says you should not use public-facing applications like Facebook Live, Twitch, and TikTok or similar applications for delivery of medical services. However, you could use FaceTime or Skype. Those are not HIPAA compliant. Skype for Business is HIPAA compliant, but FaceTime is not HIPAA compliant. Google Hangouts is not HIPAA compliant. But if that today, in this world of social distancing that we live in, is the only way you can connect with your patients, then it's okay. Medicare is not going to issue penalties, and they are not going to really have any negative effects for using a non-HIPAA compliant platform during the current pandemic. We don't know for sure what will happen after that. but I'm sure HIPAA rules will come back into play at some point in time. Okay, Indiana. Indiana, the executive order says, from the governor says that you can use any real-time interactive consultation, including telephonic. So you can have a telephone conversation for Indiana Medicaid, but not a text and not an email. Michigan, the executive order from their governor says that the connection should be an audio and visual service delivery. So again, you're talking about a synchronous video conferencing video conferencing platform. You can have telephonic calls, so a phone call is allowed for up to 30 days after the discontinuation of the emergency or the first of the following month. So that's very specific. So basically, they're saying, hey, you know, we realize this is going to come to an end at some point, and after that, you've got 30 days to get into compliance with whatever the normal Medicaid rules are going to be in the state. Ohio also says you should not use a public-facing application, specifically mentioned Facebook Live, Twitch, and TikTok or similar applications. Here at the UMTRC, we are not going to recommend a non-HIPAA compliant software for your video conferencing platform. We realize that these are different times, different measures. Be creative, do what you need to do to take care of your patient. But I think you're going to like it. I've only, all the time that I've been doing this is about 10 years now. I've only had one provider say that they didn't like providing services via telemedicine. So I think as a provider, you're going to like it. I think the patients are going to like it. And I don't think you're ever going to go back. So for a long-term solution, I really encourage you to spend a little bit of time looking at platforms. And we're going to talk about steps to do that. And you know, normally this is a conversation we have with folks that over a 6-month period or even longer, depending on the size of the organization, you're methodically going through different steps to start a telemedicine program. But right now, we're taking a few quick turns and trying to do this as quickly as possible. I'm going to stop here for a second, and I want to see if there's any questions, Heidi or Luke, that we need to talk about or answer regarding HIPAA, and then we're going to move to technology platforms.
Yeah, we have a question in the Q&A. I thought that Illinois executive order allows telephone only as well. Is that correct?
Let me find the order. It is one of the many pieces of paper here on my desk. All right. Nope, that's Indiana. I don't want Indiana. I don't want Michigan. I had it here. Oh, here it is. This is Illinois. Okay. Illinois. Regardless of the location. Video. So Illinois specifically says telephone, landline, or cellular. Okay, my bad. Regardless of the patient's location, through electronic or telephonic methods, such as telephone, landline, or cellular, video technology commonly available on smartphones and other devices, such as FaceTime, Facebook Messenger, video chat. Sorry, that's all. Facebook Messenger, video chat. Google Hangouts video, or Skype and video conferencing. Okay, so yes, for right now, telephone is good in Illinois.
And it's also good in Michigan. We just covered that a little bit. Mm-hmm. There's another Q&A there as well.
Anything else on HIPAA before we move on?
I have one question in Q&A that's a little general, but I think it definitely relates to HIPAA. There is a disconnect between CMS and state Medicaid programs, and what the governor decrees is only related to state Medicaid, right?
Yes. Absolutely correct, yes.
Yeah, as you can imagine, that was extremely frustrating for us during the first few days of this, but at least now every governor kind of has their own plan.
Yeah. And I was actually, I actually answered a question. I dove into this earlier this morning. So for Medicare, I don't have any slides on this, but we can address it in a later Q&A. For Medicare, they have not allowed phone. What they have allowed is, and I've got a slide on this, virtual check-ins, and we'll talk about those. But virtual check-ins, when you do those, there's a special CPT code for that, and it's not meant to be a normal office visit. It's meant to be a 5 to 10 minute quick video call that you could right now do over FaceTime or Google Hangouts or Facebook Messenger chat, those types of applications, but they're not allowing telephone at this time, last I saw. Anything else before we move on?
Let's see. There's two questions about whether or not telehealth services can be delivered with a provider in their own home, or do they have to be at another distant site?
Right now, there are some of the state orders that say that the provider can explicitly say that the provider can be anywhere. I believe I saw that in Michigan and in Ohio, but I think that pretty much anything goes right now. Be creative and take care of your patients.
And then we've got one more. Facebook be utilized as audiovisual. The UMTRC doesn't recommend using outwardly facing programs like Facebook. So I would definitely stay away from Facebook. That's one question here.
Yep.
For Michigan, for clarity, the audio and visual are required initially.
Yeah, that's normal. Michigan rules is they only pay for audio and visual, but they do have, this one was a lengthy one. Because the specificity only came from the Medicaid bulletin. Right now they do allow a specific service. So yeah, the Michigan has the specific service dates. They allow telephone, audio only right now until 30 days after the discontinuation of the state emergency. Does that answer the question?
I believe so. A couple ones that just came at yes. So Tamika said that that's fine. Then Lorraine gave us a nice update. Medicare has now allowed all telehealth for FQHC settings as this morning.
Does that mean the House passed the bill? Because I hadn't heard that. What I heard is that the bill that would allow FQHCs to be the distant site, and so for FQHCs and RHCs have special rules. The bill that wasn't passed by the Senate Wednesday night, near to midnight, would allow FQHCs and RHCs to be the distant site, so the provider could be at home and the patient could be at home. Because what happens with an FQHC, RHC, the patient is normally at a clinical site and the provider is normally at an FQHC or an RHC. So that makes the FQHC, RHC providing service to a patient at a different clinical site. They can be the originating site or the patient site, but not the distant site for Medicare. Medicaid in all 4 states we're covering today, they can be either. But until the House passes that bill that passed the Senate, and I'm sorry, I don't remember, it's the CARES Act, I don't remember the number off the top of my head, until the House passes that, and I've heard that the House is making changes, so it'll have to go back to the Senate and back. So I'm not positive unless you're hearing that it did pass since I've been looking at my email. All right, let's go ahead and move on. All right, let's get into, oops, toolkits. Okay, so we've talked a lot about video platforms that are okay for right now. But what do we really recommend? This is the URL down here for telehealthtechnology.org. This is the National Technology website. As you can see, they've got they've got toolkits, technology showcase, events, all these things. When you click on the toolkits, this is what you see. So they've got one specific section for video platforms, and then they've got a lot of other things. Depending on what services that you provide, if you're doing behavioral health, you're probably only ever going to need a video platform. If you're doing occupational therapy, physical therapy, you're probably only going to need a video platform. If you get to the point in the future, if you really continue on with some type of a telemedicine platform for your patients, you might need electronic stethoscopes. You might need digital otoscopes, all kinds of things. And there's lots of tools, lots of technology out there to enable that. So that's there. That's a resource for you to dig into. And as a federally funded, I always have to say this, as a federally funded program, we cannot make a recommendation of one platform over another. That's why we send you to the Technology Center. That is their job, is to evaluate technology. They do really good pros and cons lists. Jordan Berg is one of the most patient people on this earth. He will talk to you about technology until the cows come home. And it's on my list of things to do, to ask him to, either at the national level or at our regional level, to have him come and talk about some technology over a webinar during the month of April. All right. If you're in a larger organization that has already deployed an electronic medical record, and I picked on some of the big companies. I know there's a lot of other small companies out there, or small organizations that can't afford an Epic or a Cerner or a Meditech, that might have some other type of a medical record. I know positively Epic has a video module built into its electronic medical record that makes the process of delivering telemedicine a little bit more seamless, because you can be in the electronic medical record and do your video call and all of that stuff right in that one space, in that one software package. Other things you're going to have to figure out in your organization, if you have a video conferencing platform that is not attached to the electronic medical record, then how do you document? Those are things that we can't really tell you how to make it work. You're going to have to be creative. You're going to have to figure it out. Turn to your IT departments, to your C-suite folks in larger organizations. And as an organization, you need to make sure that you're all going down the same path. You could be in an organization that always uses Cisco products or always uses Microsoft products. Cisco has Jabber video conferencing, which is, as long as it's the secure healthcare HIPAA compliant version, is fine. Microsoft has GoToMeeting. I have heard people use GoToMeeting for telemedicine. Make sure it's HIPAA compliant and secure, that your IT people have done their best to make it HIPAA compliant. And realize, especially now, that if I am a physician and I am talking to a patient, there are other people in my house. If they come in on a conversation, then it's really not HIPAA compliant. And that's nothing that the software can do. The software is only good as any software program. It is us humans that use the software that also need to be concerned with HIPAA compliance and patient privacy and those types of things. Any specific questions about technology? Because we're going to move away from technology really fast.
I'm trying to keep up with the Q's and A here. If you did ask a Q&A and I responded to it, and it didn't answer your needs, just feel free to ask it again. Let's see. This one's a code question. we could probably answer it very quickly. G2012 CMS is telephone for CMS, but it is not considered telehealth.
That is correct.
The reimbursement rate for the virtual check-in in Illinois, do you know what that is?
It's, I'm going to say around $15.
Yeah. Let's see. We talked about that Medicare is still requiring two-way audiovisual synchronous connection. How should the health centers document telehealth encounters, both billable and non-billable?
Yeah, so this is going to be, you're going to have to figure that out for your organization. My best advice is hopefully you can still get back into your physical office space, your clinical space. If you're on paper records, then, take a paper chart and make a bunch of copies of it and bring it back to wherever you're going to be practicing for the next little while. Document everything that you possibly can. Go back to your clinical procedures in your organization. Remember, this is a clinical service. What do you document when you see patients in person? Document those same things, plus your location, the patient's location. I don't think anything else that might change.
And there's a few questions in the Q&A that are sort of general, like advocacy questions, and I want to just mention that we as a national consortium hear all of your concerns, and we feel the exact same way about more flexibility for providers and more readily acceptable billing terms for both distant and originating sites. And we also see the need among especially vulnerable populations at multiple intersections and socio-demographic indicators that may not have the best access to technology. We are advocating for all of that at the national level. It's just, right now, everything is changing so quickly. So I just wanted to make sure that everybody kind of heard that from us here first.
Absolutely. And we can advocate and educate, but we can't lobby.
Right.
Okay. Let's move on a little bit. Okay, here's and I have a 1 hour, we're halfway through our time. And at this point, when I go out and do presentations for conferences, I have a whole 1 hour presentation that I like to give about the culture of telemedicine, because it's different and not everybody's done it before, and it's scary because it's change, and sometimes that change is forced upon you. So be creative, do the best that you can with what you have in front of you. I'm going to give you a very abbreviated version, and then later in April we'll do a longer version of this. So there's 3 basic steps here. You're going to assess and define what it is that you want to do. And that's going to depend on if you are a cardiothoracic surgeon, if you're a primary care provider, if you're a dermatologist, if you're a psychologist. It's going to depend. So you kind of have to figure out what it is you want to do and define that in specific terms. You have to develop and execute your plan. It's a work plan. Then you have to implement your plan, and then you want to monitor it for outcomes so that you can tweak it. And so this is what what I'm talking about here is a plan, do, check, act cycle. If you have experienced any lean healthcare training or any Six Sigma training, and then there's another one that escapes me at the moment, you're reducing inefficiencies in your particular program, in your clinical service. So I'm going to date myself, but back in the 1990s, I read this book called Who Moved My Cheese? And it was very popular then. I don't know, maybe if I speak about it enough, it'll be popular again. But I like this analogy because we've got 4 characters in this particular, 4 mice in this particular story, and they are named Hem, Haw, Sniff, and Scurry. Now, they each have different personalities, and I know as you're looking at this and you're seeing, oh, HIM likes a slower approach, and SNF is results oriented, and HAW likes an unstructured approach, and Scurry likes to just go out and get it done. I know you've got people in the back of your mind at your organization that you're identifying with. So think about that in a structured approach to developing a telemedicine program. You have to get the entire team on board. That's everybody from IT, nursing staff, physician staff, or whatever kind of specialty, and CFO, the CEO. Everybody's got to be on board. It might not cost a lot. You might be doing this right now over your tablet or your computer or even your phone, because we have access to audio and video over all of those devices. But you need to be on the same page with your organization. The larger the organization, the more complex it could be. All right, so let's talk about COVID-19. We have all these grand plans, and now we're hit with this. So what do? Well, we do the best we can. We are constantly going. We've got other staff that are helping us, going through the resources on our website. We're tooling up for COVID-19. As Luke mentioned, the last week was just, we couldn't hardly keep our heads above water trying to answer all of the questions that we got. We do have getting started guides on our website. They are all great guides, and come at things from different angles with different perspectives. Certainly if you take a look at these, and if you have specific questions, please let us know. But these are designed to at least get you going. Again, in a pre-COVID scenario, we would spend a lot of time talking about a telemedicine room design because of the parameters around state Medicaid programs and Medicare programs. Normally patients would be seen in a clinical office, and then the provider would be at a distance site. The patient might be at a rural site in a small town at a primary care clinic, and the provider might be at an urban hospital. So we talk about patient rooms, and the type of service that you're going to be delivering to your patient is going to dictate the size of the room that the patient needs. Right now, really, we're talking about seeing patients from home, and the provider is probably going to be at home as well. So privacy, I already talked about. I've locked my door. So privacy for the patient and for the provider. It would be difficult to have, if there's screaming children or pets in the background, it would be difficult to have a calm, quiet discussion with a patient. They're going to be doing the best that they can with what they've got now. Website manner. So I like to talk about this. It's a lot different. I can't reach over and touch my patient if I'm a provider. I can't, it may be a little bit more difficult on a video, especially if I'm using a small phone screen, to see those facial expressions and be able to be empathetic to the patient's situation. So you've got to do the best you can with what you've got. You can't give the patient a tissue. You might ask them, do they have a tissue available? That type of thing. Video etiquette, we're going to talk about that in just a minute. And consent, I want to talk about that. Luke and I are getting a lot of questions on consent, and honestly it varies state to state, and Medicare has their own rules. Again, I'm going to tell you, do the best that you can right now. I didn't do a specific slide on it. I think maybe one of the 4 states had something specific in their state rules on consent. If you can get it virtually and document it. If it's just an audio consent. Right now, the patients, if they want to be seen, a lot of times are going to have to agree to be seen via telemedicine. This is our platform right now. If you've got an electronic medical record, and for long-term answer on consent, if you're a smaller organization, it may be very easy to get consent built into your HIPAA compliancy paperwork that the patient has to fill out on a regular basis, or, you know, do a clinical whatever. There's all kinds of stuff that we have to do as patients and fill out when we hit the desk there in the waiting room. If you have a patient portal, you could put something into your patient portal for consent. And I can't remember where I saw it, but some payer is talking about using patient portals. I think maybe it was Medicare. Was talking about using patient portals, and some of them do have video built into them. So that would be a great place, a fairly easy place, I think, technology-wise, to put paper and have a patient sign electronically for that. All right, vital signs. Let's talk about vital signs. I've got a slide for that. Hold that thought, but we'll get back to that. All right, I want to go back to the work plan. So again, in best case scenario, you're going to have 6 months or so. Or do we need to answer anything real quick before I move into work plans?
I think most people's concerns is basically documentation and recording.
Okay.
And then I would also just say that if you check your chat bubble, I sent a message to everybody with mine and Becky's personal email. We're trying to get through this call in a timely fashion, and there's a lot of Q&A coming in live. So if we don't get to it immediately, just send one of us an email, and we'll definitely track down the answer for you.
Mm-hmm. Yeah, and we will have all these questions, and that's one of the biggest reasons I like to use this particular webinar module version of our product, Zoom, that we use, is we'll have all of this electronic, and we'll be able to sort through all the Q&A that we didn't get to, and Luke and I can work together and flesh out the Q&A that's on our website, and then we can send it. We have your email addresses. We'll send that out as well. You mentioned consent, documentation. What else? There was something else.
No, like I said, I think it's just documenting and recording it.
Recording.
And I think,
okay.
Yeah, I've gotten some questions about what constitutes verbal consent and how do I document it.
Mm-hmm. Yeah, we'll have to dig into those because I want to give a specific answer on that. I want to talk about recording. That's okay. So we've gotten that question before. Do you record a telemedicine session? Well, do you record a live session? Again, this is clinical service delivered to a patient. They just don't happen to be in the same room with you. I wouldn't record a telemedicine event if you don't record the live event. Also, from a legal standpoint, from an insurance liability standpoint, if it's a recording, it's admissible in court. That's all I'm going to say about that. Talk to your lawyers. I'm not a lawyer, and I don't play one on TV. All right, work plans. So in a optimal environment, you're going to have several months to work on your telemedicine program to get it up and running. But all I want to do right now is say, think about these. Hopefully you're all familiar with the acronym SMART. Your goals and objectives should be SMART. They should be specific, measurable, achievable, relevant, and timely. You need to know when you get to the end that you actually met your goal or didn't meet your goal for whatever reason. If we're going to talk about, so I'll pick on Heidi with social media. If we're going to start a Facebook page and we want to know how do we know if we met our goal? Well, maybe our goal was to have 100 people follow us. And we want to do that within, I don't know, a month. Well, how do we know if we've met that goal? Well, we can track those. Facebook has a way for us to track those. But if we don't have a goal and it's not specific and timely, and we can't measure it, then we have no clue if we've met our goal or not. That's really all I'm going to say on this, unless there's other questions that have come up specific to work plans. Nothing?
No, just some more billing and reimbursement questions.
Okay. Video etiquette. I'm making fun of myself here. Today it's rainy and cloudy. I took these yesterday, So, you don't want to be coughing and sneezing in front of your patient. You don't want them seeing all of the mess that is on your walls. You don't want to wear inappropriate clothing. This is a joke on myself. It's a private pilot joke if you know any pilots. Um, I was amiss earlier. I was looking for some documentation, and I know I was down here, and I didn't say that, but I think it was understood that I'd been asked a question and I had to find the documentation. So, the patient doesn't want to see the top of your head. Looking to the side and down here you can't see where I'm pointing. Down here on the bottom right of the screen, you see I've got a window here, and you can see that half of my face was in shadow and the other half was really lit. You don't want to do that either. You want a good, clean visual for the patient to reassure them that you are the professional and you know what you're doing. So I've cleaned up my background. I've got my banner here. I have a special light up here that I shine to the ceiling so that it reflects off my white ceiling. It is a daylight that I picked up at a craft store. There's all kinds of other daylight things you can do. I don't have my overhead light on because it casts a shadow again, and it kind of discolors the pigment of my skin. So just be sensible. As far as what you wear, I know some large organizations that require the provider to wear a white jacket and have their name tag up here. I had a webinar yesterday with some physician assistants, a lot of them, and actually they were all from Illinois. And Illinois, for physician assistants, state that when you start the session, they have to say, "Hey, I'm so-and-so, I'm a physician assistant." So they can say that verbally. They can also wear their name tags. Most of them do not wear white coats. So whatever is appropriate in your situation, think about it like your patient is they're walking into your clinical room virtually over telemedicine. You're still going to want to introduce yourself. "Hey, I'm so-and-so, da-da-da-da-da." One of the things that I've worked with genetic counselors, they often have family with them. And we probably don't have any genetic counselors on today, but as a patient, the provider, you might want to ask the patient, do they have anybody with them during the visit that you can't see? Because you can't see, that's a closet door actually back behind me, and the door to the rest of the house is over here. You don't really know that my window's over here unless I told you. And you don't know what's behind my banner either. There could be people back there. There aren't, but there could be. So anything on, so you want a clean and uncluttered view between the camera and the provider as you're speaking. I have made sure I have two screens here. So if I'm glancing over here, this is where I've got my chat going and all that stuff, and I can see myself over here. But my webcam is here. I've been trying to focus my eyes on the light on the webcam so that it looks like I'm engaged with you. If I'm over here and I'm talking over here because my slides are over here, you guys don't really get that I'm paying attention to you. My slides are here, right underneath my webcam. Lighting, I've talked about lighting. You always want to be front lit, not backlit. I closed the blinds on my window. It wasn't, as I mentioned, it's cloudy and rainy today, so it doesn't make as much of a difference, but if it was sunny out, it would. Acoustics. So, and again, this is really when the patient or the provider's in a clinical setting, you've got hard floors, sometimes you've got high ceilings, can create echoes, you might have loud HVAC systems, you might have traffic outside. In a home office environment, there's usually carpet, drapes, and all of those things help to minimize echoes and absorb sound. On the TTAC side, on the technology side, they've got recommendations about webcams, they've got recommendations about microphones, speakers, all of those things you can find there. Ideal wall color, again, for the next 90 days, it's not really going to matter. I don't expect you to go out and paint your office, but in general. Light colors like light gray and light blue are soothing, work well with all skin tones. So I think, yeah, that's it. Any other questions that are pertinent to video conferencing etiquette, setup of rooms, technology, because we're going to leave this topic.
We've got one. Should persons in the room be asked to identify themselves if they are listening?
Yes.
Okay.
Anything else? Okay. All right, so I'm going to move on, and we're going to spend a little bit of time on policy. And I can tell you right now, we're going to go over our hour. So I apologize if you've got another call at 1 o'clock and you have to jump off. We are recording this. We will get it posted, and we will let you know. We will get the slides out as well. All right, so Medicare pays by CPT codes. This is still the same. They're still paying by CPT codes, and if it's not on the list that I'm going to show you, then they're not going to pay it. Medicaid, each state does their own Medicaid program, and they have the ability to modify that for their state. As of last year about this time, all 50 states and DC do cover live and interactive telemedicine. So pre-COVID, these are the 4 things that we would always talk about for Medicare. And the first 2, the patient being outside of a metropolitan statistical area and in a designated originating site, are currently waived during this national pandemic. Medicare did not add any additional telemedicine codes or CPT codes for this pandemic. Now there is a U001 and a U002, but those are for testing for COVID. Those aren't telemedicine codes. Medicare also did not expand the list of eligible practitioners, so that is still the same as it was prior to the pandemic. If we were pre-COVID, this is what we would talk about where to find out whether or not you're eligible. If you're in a rural county, rural census tract, that has been waived for right now for Medicare. You don't need to worry about that right now. Medicare in the last week has updated their annual Medicare Learning Network booklet. This contains all of the information you need to know about billing Medicare. They did put in here an alert about COVID, and this links to their fact sheet and their frequently asked questions about the 1135 waivers, all of that information. This is what that looks like. Just the listing of codes and the definition of the services. If you've never done telemedicine before, this is what it visually looks like when you're billing for telemedicine. Usually, the patient is at a clinical site, and that's called either the originating site, the spoke site, or the patient site. And that facility, that organization where the patient is, would bill Q3014. I didn't do my fancy little cross hash, but this is kind of gone away right now. If the patient's in their home, you're not going to bill Q3014. They're not at a medical facility. What you are going to bill is for Medicare, Part B professional fee, and your normal CPT code with a modifier of 02. So the provider site is sometimes referred to as the distance site or the hub site or the provider site. Traditionally for Medicare is in an urban area. Any questions on this slide before I move on?
Yeah, there's a couple. Let's see. Will Medicare pay for telehealth virtual visits for licensed clinical social workers and family counselors?
Family counselors, I don't think is on the list. I believe LCSWs are. Hang on just a second. I've got that right here. Authorized originating sites. Distant site practitioners for Medicare. Physicians, nurse practitioners, physician assistants, nurse midwives, clinical nurse specialists, certified registered nurse anesthetists, clinical psychologists, and clinical social workers. It doesn't say licensed clinical social workers. Is there a difference between an LCSW and a CSW? I don't know.
I was going to say there's one more. When you mentioned billing Medicare, does that include Medicare Advantage plans?
Yes. There are, and if you send us an individual email, we will find that there have been some changes earlier this year to Medicare Advantage plans to be more friendly to telemedicine. Also, a registered dietitian or nutrition professional can bill Medicare. Anything else?
Is the place of service 02 or that's just the modifier?
Oh, place of service is a field on the 1500 form that you put 02 to indicate that the patient was seen via telehealth. Medicare is no longer using a modifier. They used to use GT as the modifier. And we were talking yesterday or sometime in the last couple of days, there is a modifier called CR, but Medicare is not asking for that. And that means that that was done during a pandemic or something like that. But Medicare is not asking for that at this point. All right, so policy stuff. We talked about the virtual check-ins. These two links explain the virtual check-ins and some other codes that came into play for Medicare in early 2019. These are not telehealth codes, but the patient can be at home. It doesn't matter where the patient's at, so you can still bill these now. But we talked about, was it G1012, something like that? The virtual check-in code, they are not going to pay at a very high rate. They're only like $15 or something like that. So just be aware of that. But you can use them right now if you want to. All right, we really already talked about this FQHC thing. If you have any questions specific to FQHCs and RHCs, there's more information on our website. You can email us individually and we'll walk you through the situation. All right, so what I want to get to here, and we actually really did talk about a lot of this, but I wanted you to have this documentation. The URLs at the bottom of these slides are what's on our website right now. These particular state resource documents have not been updated for COVID yet. We're getting there, but we're not there yet. So this is pre-COVID-19, what Illinois Medicaid would reimburse for. Illinois has a parity rule that's interesting because it says if they choose to do so. Whoops. Right now, they are doing so. All commercial providers are paying in all 4 of our states. They've basically been mandated by their governors that they must. But there is when we get through this, there is a bill in Illinois legislature that would improve the law on the books for parity for commercial payers. All other states, Indiana, Michigan, and Ohio have, Indiana and Michigan have parity rules. Here you can see Indiana's pre-COVID-19 language. Ohio instituted a parity rule. Let's go ahead and get to, and there's more stuff for Indiana there about speech language that just came out this year. Here's Michigan. They have not done remote patient, or they've not done, store and forward or remote patient monitoring. None of the 4 states pre-COVID did remote patient monitoring. If there are DEA questions, put that in the Q&A and we'll talk about that. Otherwise, we'll save that for a separate conversation. What I wanted to get to was Ohio. They had huge sweeping laws for their Medicaid population in July of 2019. As part of that, they enacted a parity rule, but it doesn't fully take place until January of 2021. Right now, because of COVID, they're doing it. But if we get through COVID and go back to normal before January of 2021, there might be a lag in commercial reimbursement in the state of Ohio. I don't think so. I don't think they'll go back. I think they'll just implement the rule early. But so I've still got several slides, and we did have folks on here from Ohio. Again, we're going to get you all these slides. If you have participated in any of our stakeholder calls, which are out on the website, they're quarterly this year. You can go to our events page and register for those. We've covered this heavily in our Ohio stakeholder calls. But I did want to leave all of that because there are several pages of it. Ohio Medicaid, excuse me, did a great job with their fact sheet, which is part of the Ohio, where's it at here? This particular resource on our website that is specific to Ohio, this URL at the bottom of this slide. They have spelled it out very, very clearly in a couple of pages of a Medicaid fact sheet for their state. But they added a lot of rendering providers here, and they give you all of the different provider types to put on the bills. They did exclude jails.
Hey, Becky, real quick. One of the things that I see kind of recurring in my technical assistance calls, and then I got another one here in the Q&A, is how do you navigate the patient-initiated requirement?
You know, I don't have a good answer for that yet. You and I are going to have to dig into that one.
Yeah.
I don't know.
Okay. Yeah, I just saw one come up in the Q&A here, and I had a couple calls on it yesterday.
Okay. Yeah, we'll have to dig into that one. All right. Oh, and here's the parity. I talked about this already. So that parity rule for Ohio that passed last July was only 2,000 pages long. All right, I already told you we're going to go over, and we're getting to the end of this. I got some general questions, and then I want to spend some specific time. We're going to get into, we'll talk about prescribing, and we'll talk about vitals in these questions. And then if we have other questions we want to answer live, then we'll do so. Some general questions. Do we need any special credentials to provide telemedicine? There's not a separate certificate for the provision of telemedicine. Again, you're not providing any type of different clinical service than you normally would provide in person. But right now, even during COVID-19, you must be licensed in the state where the patient's physically located during the telemedicine visit. I did hear Vice President Pence say that they were going to expand licensure cross-state, especially Illinois and Michigan and Ohio are all around Indiana, and we see a lot of cross-state activity. I have not seen any state say that they're opening up cross-state licensure. Illinois did say something about, and I'm not sure, I'd have to go back. If you have a question on it, put it in the chat, or put it in the Q&A, we'll dig into it. It said something about allowing providers out of state, but it wasn't specific enough for me to understand if it was a provider that happened to be physically in Indiana or Michigan or Iowa and licensed in Illinois, or what. I couldn't really understand it. But sweepingly across the nation, I have not seen any relaxation of cross-state licensure. What equipment do I need? We've talked about that. there are some exceptions. Some of the payers are allowing phone calls. We talked about the code. That it's not a telemedicine code for Medicare. What was that code? Do you remember, Luke? We can document that somewhere.
I don't off the top of my
That's
head.
okay. That's okay. We'll find it and we'll document it. Most state Medicaids are allowing telephonic calls at this point. Is telemedicine appropriate for all ages or specialties? Right now, you're going to have to use your best judgment. Certainly, some things don't really lend themselves to telemedicine on an ongoing basis, but right now, that might be the best that you can do. Can telemedicine visits be for new patients or only established patients? Right now, either. Some state laws, especially when you're talking about prescribing, have restrictions on whether or not you can prescribe if it's the first time you've seen the patient. If you've only seen the patient via telemedicine, you've never seen them in person, you can't always prescribe. We'll get into controlled substances in just a moment. Right now, I would say that you can see a patient for the first time and prescribe. If it's an antibiotic, I think that you're going to be okay. Again, if there's specific questions, let us know in the Q&A. There are links to all of the state documents that we have been able to find on the website under the COVID resources, and it should be listed in your state documents. Can I order outpatient tests? Oh, I forgot to fix that. I will fix that before we send the slides out. Or labs for a patient during telemedicine visit? Yes. Can meds be prescribed? Yes. What about controlled substances? I'm going to hold off on that. You've got the slide. If there's DEA questions, we'll come back to those. How do I perform a physical exam and get vitals? So if the patient's at home and there's no one else with them, you're going to have to rely on your patient. Most houses have thermometers. They can take their temperature. They can show it to you. They can tell you what their temperature was. A lot of people have blood pressure cups at home. Again, they can do that themselves. They can tell you. In your documentation, you may want to say that those vitals you were relying on the patient. Patient took those vitals and it wasn't taken by a medical assistant. The patient might have a fitness device that they can say, oh, here's what my pulse is, or they might know how to take their pulse. These are unprecedented times. Use your best judgment, be creative. What if the patient needs to be seen in person? Well, you're going to have to follow your organization's guidelines. And those emergency preparedness protocols. I've heard lots of examples from hospitals in our area. They're all taking care of their patients in their own way. You're going to need to know that. You'll be plugged in with your local hospitals. If an in-person visit is determined, can I still bill for a telemedicine visit? Yes. What is the reimbursement? The reimbursement for telemedicine is going to be the same as the reimbursement for in-person. I'll make up some numbers here. If you have an inpatient clinical visit with your primary care doctor, it might be $150 billed. Maybe the commercial insurance pays $120. Maybe Medicare pays $80, and maybe Medicaid pays $60. Those are still going to be the same. So the reimbursement depends upon who's being billed. How long should visits be scheduled for? Well, how long do you normally schedule your in-person visits for? It's going to be the same. Does my collaborating doc have anything to do with these visits? And this was specific for those physician assistants that I spoke with yesterday. Right now, during these unprecedented times, probably they may not have anything to do with the video visits that you're doing, but that we have not seen any relaxation of collaboration rules or chart reviews. I have not seen anything talking about any of that. Once the COVID-19 pandemic is over, do I lose my ability to provide telemedicine services? Probably not. if you're, especially I'll pick on occupational therapy, physical therapy, most folks didn't allow that before this waiver, the waivers that have happened with COVID. We don't know what kind of reality we're going to go back to. Your patients are going to like this. You're going to like this. I think that there'll be a lot of changes when we go back to normal, whatever normal becomes after this particular pandemic is over. Oh, I left this in. So this is specific to Illinois. I did these last night. But this is our National Policy Center for any state. You can go to cchp.org. I gave you that earlier. And you can click on telehealth policy and you can get either the current guidelines for your state, especially if you're not in one of the 4 states that we cover and have specific resources for. And then you can also get a legislative update for your state and see what bills regarding telehealth, telemedicine are in place in your state. They also have a lot of resources and fact sheets on their website as well. I told you we have a COVID-19 page on our website under resources. We've blocked everything out. We may be changing that, but it's all going to be under COVID-19 resources. And you can go there to find more information and some of the information that we've talked about during the call today. Again, I want to highlight that we have multiple ways that you can connect with us: Facebook, LinkedIn, through the website. Sign up for our newsletter. We will be getting more information out about additional programs and webinars that we're going to do virtually in the month of April. You'll also probably will see on our website that we do have an annual conference scheduled. It's scheduled for the middle of July in South Bend, Indiana, which is northern part of Indiana. Right now, we're still on for an an in-person conference in the middle of July. It is our hope that things will quiet down and go back to at least semi-normal by that time. We will not make any kind of final determination about that particular event until we get a lot closer. So it is out there. You can register for it. There is my contact information. Luke said he put his email in the chat or in the Q&A as well as mine. Are there any final questions we need to answer today?
I just want to tell everybody who's got questions in the chat, if you didn't hear earlier or maybe joined a little bit late, we've got about 25 inquiries still sitting there. The Zoom webinar feature allows us to capture that, and we will respond to those as we kind of sift through the information.
All right. Thank you, everyone. I hope this was helpful, and we will we'll be emailing out the link to where the recording is going to live and the slides early next week. Thank you.